Good evening to everyone. Welcome to the master classes which are conducting with the Yashoda Hospitals along with the Indian Society of Critical Care Medicine Hyderabad chapter. Today we have the most common problems of obstetric emergencies like PPH, DIC and MODS. That is the bread and butter for the intensive care medicine, and these are the most common exam cases will be there for the students and equally practical also. To take these cases together, we have the eminent examiners, the senior most doctor, Dr. B D Bande, who is the Joint Director of Critical Care and Emergency Medicine Services at Noble Hospital and Research Center at Pune. The second senior examiner is there, Dr. Yash Javeri, who is the Director of Critical Care and Emergency Medicine at Regency Healthcare Services at Lucknow. And the students which are going to present the cases, these are both are our DrNB students in the final year, Dr. Keerthi and Dr. Prathiksha. They will be presenting the cases as we are discussing in the examination, and request the examiners, Dr. B D Bande and Dr. Yash Javeri, to assist them. And at the end, we can take more discussion, more questions which are there asked by the attendees.
So we are privileged and honored to have both the senior seasoned examiner on board. Thank you for accepting our invitation to be on board, Bande sir and Yash Javeri sir. It is a privilege for us, sir.
Thank you, Dr. Venkat. Thank you, Dr. Madhusudan.
Thanks, Venkat, for giving us the opportunity to interact today on this very important topic.
It's over.
Thanks a lot, sir. Thank you. Over to Dr. Keerthi and Prathiksha. We can start with the presentation of the case.
Good evening, sir.
Good evening.
A 27-year-old female who is G2P1L1 underwent elective LSCS on 9th March 23 at 12 p.m. Later on in the evening at 4 p.m., patient had developed tachycardia, hypotension, and pain abdomen, and on examination, bleeding was revealed from pervaginal and from the suture site. They diagnosed it as atonic PPH, and she received 2 units of whole blood, 3 units of PRBC, 4 units of fresh frozen plasma, and underwent emergency hysterectomy at 11 p.m. on the same day.
Yeah, Dr. Keerthi, one question. So go back to the previous slide, please. Suppose this patient was in the ward, or where was this patient at 4 p.m.?
Sir, actually, she underwent LSCS selectively at outside hospital, sir.
Okay. So, yeah, we have triggers for medical emergencies, EWS, early warning scores, we know. Do you have any dedicated triggers for obstetrics, or do you use same? Suppose this was your hospital only. Will you use EWS, modified EWS, or something else for this particular patient?
We use maternal EWS score, sir.
What is it? Can you please elaborate a bit?
Any postpartum lady with BP of less than 90 and tachycardia of 120 and respiratory rate of greater than 30, we should be considered she is bleeding heavily, and PPH protocol has to be activated.
Yeah. See, yeah, that's good. So modified early obstetric warning scoring system is a little difficult than the routine EWS which we use in the clinical practice for normal patients. So this MEOWS has few components: respiratory rate, saturation, temperature, systolic and diastolic blood pressure, heart and neurological response. We should be familiar with this score. So if patient has 1 red, it is a rapid response team alert. Or if the patient has 2 yellow means 1 level higher, suppose respiratory rate of 21 to 30, plus temperature of more than 38 or less than 36. So we should be familiar with this score, and if we have a reasonable number of obstetric patients, we should be using this score in our clinical practice. So people will ask in the exam. Please be familiar. Thank you.
1 yellow.
Yeah, please, next slide.
She was referred to our hospital, sir. At 1 a.m., she came to our hospital in a drowsy state, and her vitals at presentation are heart rate 168 per minute and BP 60 by 40 mmHg and SpO2 98 with 15 liters of oxygen, which is delivered through NRBM. and she had nil urine output. She was intubated in ER in view of worsening GCS and hemodynamic instability, and she was resuscitated with 2 units of RL and started an R-adrenaline support with 1.5 mx per kg per minute and vasopressin with 2.4 units per hour. And she was transfused with 4 units PRBC, 1 SDP, and 4 FFPs were transfused in ER.
So I'll again stop you here. Why were you giving ringer lactate? Just a question. Any particular reason?
No, sir. She can be resuscitated with any crystalloid. It can be NS or RL, sir. Or we can use balanced crystalloids also.
So why did you choose RL in this particular? No particular reason? Was there hypochloremic acidosis or something like
No,
that?
sir. Nothing is there.
RL is a balanced crystalline,
Yeah.
close to the physiological pH.
And what was the map? You have added vasopressin also in the beginning. What was the map you were targeting in this particular patient?
And should be targeted at 60 mmHg, sir.
50 to 60.
For this particular patient with nil urine output, will you target higher or 60? Nil urine output.
50 to 60.
60
We can
is
permissive
the target.
hypertension.
Permissive hypertension.
Because the patient is having ongoing bleed. Okay.
Ongoing bleeding.
But if
And
patient is oliguric or patient is in early renal failure, we need to target a little higher, maybe 70 to 75 also in many cases, or a little higher. But as the patient was having ongoing bleed, so we will continue with the hypotensive resuscitation.
I go ahead, sir.
Yeah, thank you. Please proceed.
The day course in ICU on the day 1, patient was shifted to ICU, and we had announced the massive transfusion protocol, and invasive lines, arterial line and central line was secured, and temperature monitoring with nasopharyngeal probe was placed, and we noted using from all invasive lines, oral cavity and soakage from all dressings. And the initial drain immediately drain got filled with 1 liter in few hours, and we suspected DIC. Invasive mechanical ventilation was continued, and the patient was noted to have nil urine output, and 3 units of PRBC, 3 units RDP, 3 units FFP, and 10 units trio were transfused in 1:1:1 ratio, and recombinant factor 7A was also given. 2 mg was given, and her ABG showed metabolic acidosis, pH of 7.05, CO2 of 35, bicarb 9.8, and lactate of 11.5.
Dr. Bande sir, you want to comment here something?
Yeah, so go back to your second slide. Go back 2 slides backward. So was the intra-arterial line done in the operation theater or in the ICU?
Sir, she was shifted to ICU, and we have secured the lines, sir, in ICU only. We have.
So will intra-arterial line done right at the admission in the operation theater help? Because she's on a very high dose vasopressin and noradres as well. They are not done it, that's fine, but will it help intraoperatively?
Sir, actually, she was shifted from outside hospital, sir, where she was underwent, where she had underwent LSCS, and then she developed.
Where was the surgery done?
In
underwent hysterectomy was done in your hospital, correct?
No, sir. No, sir. No, sir.
No. Okay. Fine. So that's okay.
But
so
sir,
everything happened outside.
Bande sir, we can create hypothetical situation, and sir, these all the whole purpose is to have a widespread interaction. So you can ask them, so sir, assuming this case would have been in your hospital. So Keerthi, Dr. Bande sir is asking, assuming this case would have been done in your hospital, this can be possible anywhere. So what will be your reaction? Every time your discussion is this case has been shifted to outside. Agreed, but you can talk about a situation in your.
I will give you another situation. Now you were called to the emergency to see this patient as a critical care outreach. Will you insert arterial line or not at this point in the emergency room?
Yes, sir. We should insert arterial line and the central line also, sir. For fluid resuscitation and in BP monitoring, we should insert arterial line and central line, sir. Along with the resuscitation, we have to place these lines also, sir.
So you were planning to insert, what central line will you insert in this particular patient?
Multi-lumen catheter, if it is available, multi-lumen catheter would be the choice.
Route?
Or
Which route will you choose?
if it is in emergency, he is in severe shock, we can proceed with femoral lines.
Otherwise?
Otherwise, we have to place in IJV in unrestricted exit.
Subclavian you want to avoid because it's a non-compressible site in such a situation. Right, please proceed. Now, go back to the third slide. Novo 7, activated factor 7.
So before you go to that slide,
Sir.
the patient was here in the emergency room for quite some time because you have to procure blood components. So it takes at least 45 minutes, correct? So those 45 minutes will be very, very vital. And as Yash was saying, if everything is possible, the invasive lines, including intraarterial and central venous line, etc., would ideally be done in the emergency unit itself, because that's a very precious time. Patient is in a very, very severe shock. So if that is done, then you can be really precise about your vasopressor management. And of course, you can have a ultrasound and echo help to look into also the volume load which has been previously given and what you are going to plan your the emergency room. So my question, purpose of that question was that I was wrong in pursuing the operation was done in Yashoda, but maybe it was done outside, but the first hour till the time components were available will be very vital for this patient, and that will decide the prognosis as well. Though patient has come about 12 hours later than the has come from the first surgery which was done, and 12 hours is a very long period to have blood accumulated in the abdomen, and then we had she had a PV bleed and the suture line bleed. So a lot of time was actually lapsed before, and she already had a very, very bad shock. Okay, so the purpose of asking was that as early as possible, the lines and the monitoring should start.
One more question, Dr.
Yeah,
Keerthi. Why did you give factor 7? What is the level of evidence for factor 7 in PPH? And what is the WHO recommendation now?
Sir,
Some years back, like 12, 13 years back, we were using it on a compassionate ground for all major breeders obstetrics. But now the evidence is bleak. So what is your take on this?
Sir, as she had received PRBC and platelets and FFP in the outside hospital and continued to have bleed, we have given factor 7A in benefit of doubt only we have given, sir. And we don't have any FDA approved role of factor 7, but we have given, sir, in benefit of doubt we have given.
So initially, say 10, 12 years back, for any major obstetric, we all were using factor 7, and it was there in all the guidelines, Australian and American obstetric society guidelines. But now the WHO has also given a recommendation against factor 7 for any major obstetric bleed. Secondly, we all understand obstetrics is a procoagulant state, and factor 7 complications we all know are because of the hypercoagulability because of factor 7. So we have to be very, very careful. But this was a very, very crashing situation. So anyone would have done the same, I believe. Yeah, please continue.
So go backwards. So how do you interpret this blood gas?
Sir, with pH of 7.05, it is in acidosis state, sir, with PCO2 of 35.
First step is to check the validity of the ABGs.
Yeah, assume it is valid. Go ahead.
Sir, she is in metabolic acidosis, sir, with hyperlactatemia, lactates of 11.5, sir, with PCO2 of 35. And the hemoglobin, she is severely anemic with HB of 3, and calcium, it is not written, sir, and potassium of 12.
First step is
Calcium? What is the calcium?
It is
Not
How do you interpret the potassium?
Sir, she has received up to 6 units of PRBC and blood products. We assume because of these products, she may have hyperkalemia, sir.
Okay, so is it very alarming or you will accept and continue further? What was done
Yes,
for
sir.
that? After receiving this blood gas, what was done for this potassium?
Sir, potassium correction measures were given, sir, with 10 units of insulin in 5% dextrose and aspirin nebulization and calcium gluconate were given, sir. 1 gram.
5% dextrose. It is 25% dextrose, not 5% only for correction. 20 or 25, whatever.
25%.
Yeah. CO2 is
Why
okay
25?
for, sorry, sir, please.
No, yeah, you asked that. Why 25%? I'm asking Prathiksha. Why 25% and not 5%? You're giving insulin, correct?
With insulin,
Yeah, so with insulin, obviously the side effect will be going sugar down, correct? With the insulin, the intention is to bring the potassium down, but with that sugar also will go down. So if you give 5%, which probably may not be adequate, though there is no comparative study, but logically speaking, 25% sugar given along with that should suffice to maintain or prevent hypoglycemia. That is the whole purpose. It's simple. What do you think with this massive kind of transfusion will happen to calcium, which is not, I think, seen in the blood gas, but will there be hypocalcemia? Because here the purpose of calcium giving was for potassium hyperkalemia treatment. But per se, would this patient require calcium? And
Yes,
what
sir.
would be the predicted value of calcium on this blood gas in case it was there?
Severe hypocalcemia would have occurred, sir. And it should
Why
calcium
there is hypocalcemia?
because of citrate chelating the calcium present in the preserved PRBCs, chelating the calcium, hypocalcemia would have occurred, sir.
So was calcium given at this point?
Yes, sir, we have
Additional
given.
calcium.
Yes, sir, we have
How
given.
how much calcium was given?
Sir, 1 gram of calcium chloride given through central line, sir, over 20 minutes, sir.
You know how much milliequivalents that ampoule of 1 gram will, 1 gram will contain? Have you used calcium gluconate before?
Yes, sir, we have used calcium.
Do you know the difference between these two?
Yes, sir, calcium chloride contains higher elemental calcium than calcium gluconates.
98 milliequivalent.
Are you sure? Anyway, go further. Let's see. So just keep in mind the difference and the quantification of calcium.
So, sir, there are a few questions. We will take it. What is RDP, Dr. Prathiksha, Dr. Keerthi? Can you explain what is RDP, what is SDP and difference precisely?
Sir, RDP is pooled platelets from different donors, sir.
Yeah.
Platelets will be collected from different donors and they are pooled. Whereas SDP is from a single person.
Yeah. So RDP is randomly donated platelet concentrate, SDPC single donor platelet concentrate. RDP, because the volume is less, will increase platelet to a lesser extent. SDPC will be better. Another question, Dr. Mansoor again. Can 10% dextrose be given instead of 25% glucose for hyperkalemia?
Yes, sir, it can be given. It can be given, sir.
Yeah, but the general thing is to give 25% dextrose, 20 unit insulin over 20 minutes. 20, 20, 20, they say to remember. Okay, please proceed.
In ICU, we have targeted a temperature at 98 Fahrenheit and in view of severe metabolic acidosis and persistent hypotension requiring multiple vasopressors and inotropic support and olivuric state, we have initiated HERA on CRRT and temperature was targeted at 98. And her lab
So investigation. What was the temperature on admission?
temperature was 98.
Was she hypothermic?
No, sir. She was not hypothermic.
She was not hypothermic. Okay. What is the triad of death described in this context?
The legal triad of acidosis, coagulopathy, and hypothermia.
Hypothermia. So most often these patients received from outside with such a huge load of components and fluids given are invariably hypothermic. If it was not measured or measured, that's fine. If she was not hypothermic, she's lucky. Maybe measures were undertaken. And now this triad has been expanded to diamond, adding hypocalcemia. I'm again coming to that component. And do you know your blood gas machine gives ionized or total calcium?
Ionized calcium.
Which the blood gas report, which is shown, the calcium is not stated, but do you know in what form it comes? Is it ionized or is it total? What is the normal calcium level?
Ionized is 1.132.
Yeah, 1.1 to 1.3 maybe. That is a normal range which comes on blood gas, which is ionized, elemental ionized. Okay, total we get 9 to 11 milligram%, which will get the routine report. So total is that. Then there is ionized, which is almost half of it, the total, and then it can be in millimoles and milliequivalents. Okay, so I hope you know the differences between milliequivalent and millimoles. We'll not go into those details, but for improving the temperature or targeting the temperature, what kind of measures were undertaken, which is often neglected. Why I'm stressing this, because hypothermia is often neglected. You were lucky that patient was normothermic on admission, but what measures you undertook in the ICU?
Warm fluids were given, sir. Then
How were the fluids warmed in your ICU? How they are done?
We have inline warmers, sir, and with bare hugger we have maintained her temperature at 98, and we have
Right. So bare hugger, that is hot air blower and online warming of fluids, or you can have cabinets to warm the fluids, which are often kept ready most of the times in the ICU if required or in OT. So that's the way, because hypothermia is often neglected, and I think all have to take a precaution right from beginning. Please go ahead.
Very valid point sir has raised. This particular patient or any patient in shock is at risk of hypothermia, and it will further precipitate the coagulopathy. So we have to take active measures to stop or prevent hypothermia. We have to be actively preventing it. Is the bare hugger there in this picture? Body warmer, is it there in this picture? Is it in use? Not the machine, is it the sheet there?
no, sir.
We don't know.
Probably is not showing, but they have taken care. That's it.
Yeah.
So that is there in most of the ICUs. Yeah.
But if bare hugger sheet you are putting, you should not put a blanket over it. Why? Because the air cells in the sheet of bare hugger, those get warm air. And if you put a blanket or whatever over the sheet, it's get deflated. So never put a blanket over the bare hugger sheet. Okay.
They may have lighter blankets.
Yeah.
Yeah. The blower is good enough to prevent we can always make it whether they are really collapsing or not. So I don't think that will be a big issue. And hot blow air blowing. Only thing is temperature monitoring has to be done. How are you monitoring the temperature?
Sir, we have inserted nasopharyngeal catheter, sir, temperature.
Correct. So the surface temperature will not be adequate. It has to be core temperature monitored by either methods, and you are absolutely right in saying that. Please go ahead.
The lab investigations revealed of hemoglobin of 3.6, platelet count of 70,000, and PT of 23 seconds, and APTT of 31.5 seconds, and serum fibrinogen of 99, and serum creatinine of 1.2, total bilirubin of 1.8, SGOT of 1006, and SGPT of 661, and her pH of 7.05, PCO2 of 35.3, and Bicarb 9.8, and lactate 11.5.
Can you explain the parameter arrangement one by one?
Sir, her hemoglobin now 3.6, sir. She is severely anemic and platelet of 70,000. Thrombocytopenia and PT of 23 with the high INR and APTT of 31.5, which is elevated, and serum fibrinogen is 99, it is very low, and serum creatinine of 1.2, it is slightly high, and total bilirubin of 1.8, it is high, and SGOT it is elevated, and SGPT is elevated, and pH is 7.05, which is very less, and PCO2 of 35, which is borderline, and bicarb of 9.8, and lactate is 11.5, sir.
What is TCP coagulopathy?
Thrombocytopenic coagulopathy, sir.
What does that mean?
With platelet count of less than 70,000, if it is less than 50,000, there is microvascular bleeding will happen in cases of hemorrhage, sir, and it should be targeted at above 50,000. So
You in between you utter a word DIC, am I right? In between you said DIC. Last slide when you are before I asked the question,
we have
you
suspected.
said.
Yes, sir.
So how why are you saying that? Is there something called dilutional coagulopathy? And if it is a dilutional coagulopathy and DIC, how do you differentiate?
Sir, dilutional coagulopathy and DIC we can differentiate with INR, sir. In DIC, INR will be elevated, and dilutional coagulopathy, INR will be normal. And
Why would it not be deranged in dilutional?
Dilutional, it will because of volume added to the blood, there will be dilution of coagulation factors, sir, but they won't be get consumed. So INR can be elevated, but D-dimer and FDPs will not be elevated in dilutional coagulopathy, sir.
See, D-dimer here doesn't keep a relevance because any patient who's having post-operative clots anywhere, D-dimers are likely to be deranged. So D-dimer test will not really help in this scenario. Dilutional coagulopathy, INR may be deranged. It probably, as you say, may not be the situation all the time. It may often will be deranged. So you know the mechanism of dilution, it's a dilution, and in DIC it is consumption. So in consumptive coagulopathy, D-dimer is one test which we initially do, which may not be relevant here. Otherwise, how do you differentiate? And is there any difference?
Fibrinogen, yeah. We can differentiate with fibrinogen.
Will be less in both. So it's not very easy to differentiate. Only thing is treatment doesn't differ much. How does the treatment differ? Whether it's dilutional or DIC?
No, sir.
Yeah, because consumptive coagulopathy, we don't have any right away evidence of primary coagulation. Here we always detect the patient where they are bleeding. So probably treatment will not differ. Go ahead.
One more point. Dr. Keerthi, suppose this patient, we have not taken a history so far. We don't know whether this patient has a chronic liver disease or something like that. So, coagulopathy of liver disease and DIC. The clinical picture will be also same, and the lab parameters, as Dr. Bande already told, it will be same. So DIC cannot be diagnosed based on a single parameter, or even on data set also it cannot be. It has to be a clinico-pathological correlation always. Okay, please proceed.
After transfusions and all, her hemoglobin got better to 6.5 and platelet count improved to 75,000 and PTINR reduced to 19.9 and APTT increased to 45.3 and serum fibrinogen increased to 207 and serum creatinine increased to 1.5, total bilirubin of 1.7. SGOT reduced to 565, SGPT reduced to 479, and her pH improved to 7.53, PCO2 of 26 and bicarb of 22, and lactate reduced from 11.5 to 3.
So how do you interpret the blood gas picture?
Sir, she had respiratory alkalosis, sir.
Reason?
But we might have a hyperventilated her, sir.
Yeah. So patient got little hyperventilated. That is the reason. Okay. How much bicarb was needed so far? Did you give the backup on it?
No, sir, we didn't give it.
To treat the metabolic acidosis?
No, sir. We have started her on CRRT, sir. We didn't give any backup.
Okay.
So for a massively bleeding patient at the critical bleed, what is your target hemoglobin, platelet, INR?
Sir, hemoglobin of greater than 7.5, platelet count of more than 50,000, and INR less than 1.5 times the control value.
In a patient with DIC,
Fibrinogen should be, in obstetric cases, fibrinogen should be maintained more than 300 mg per deciliter.
if your patient with DIC is not bleeding, will you give FFP and cryoprecipitate as you did in this case if patient is not bleeding?
No, sir. We shouldn't give, in early phases of DIC, there will be high risk of thrombosis. No, we shouldn't resist. We shouldn't give FFPs or cryos, sir.
Okay. Proceed, please.
In view of ongoing bleeding with significant drain, patient was given 4 units of PRBCs and 4 units of FFP and 4 units of RTP and 20 units of cryoprecipitate and was planned for exploratory laboratory.
I'll stop again. Sorry. FFP 4 unit, is it adequate dose? What is the dose of FFP?
15 ml per kg.
15 to 20 ml per kilogram. So this looks very, very less. Although you have also given cryoprecipitate, but the dose should be 15 to 20. But cryoprecipitate will take control. Okay.
So to overcome this discrepancy of estimation, how much will be needed in what quantity, is there any investigation which can help to be more precise?
Sir, if it is TEG or thromboelastography or ROTEM would be more helpful, sir, if they are present. And we can
How
give
does it help? How does it help?
ROTEM 15A5. If it is more than 15 mm, then fibrinogen is equal to 300 milligram per deciliter. ROTEM will. If it is less than 11 mm, then we can transfuse fibrinogen concentrate or preps.
Amplitude, does it help?
Sir?
Amplitude on the TEG?
Sir,
Have you used TEG anytime?
no, sir, we didn't use.
Okay, fine. So then I think you must read about TEG because there are multiple components, right? Reactivation time, then amplitude, then lysis time, all those things. It doesn't matter even if you're not used it, that's fine. But it does help to give a many ideas about various component requirement, and amplitude and lysis time, etc. They will all help you to decide which component is in need for that particular patient. So you can read all that later. Okay, so decision of exploratory laparotomy was taken only with the basis that the patient was still bleeding, correct? So how was it decided that it is a surgical bleeding and not the coagulopathy bleeding?
Sir, we have done ultrasound, sir. In that there are blood clots and are present, sir. So we have decided for exploratory laparotomy.
So what was the obstetrician's opinion? Where is the patient bleeding from? Hysterectomy was already done.
She had a hemoperitoneum also, sir. Diffuse oozing from the blood vessels from the previous surgical site. So we have decided for exploratory laparotomy.
Okay, go ahead.
The total blood products she had received in our ICU, PRBC of 10 units, SDP of 1, RTP 4, FFP 16, and cryo 30 units. In day course,
How was the hemodynamics when you planned the surgery, exploratory laparotomy?
sir, she is requiring vasopressors of low support, sir, of 0.5 mg per kg per minute with BP of 110/80 and urine output improved to 15 ml per hour. And CRRT was stopped in view of hemodynamic stabilization, and she became conscious, awake, and oriented, sir.
Preoperative.
Yes, sir.
Exploratory laparotomy was planned, is it?
Exploratory laparotomy was planned, but she improved, sir. Later on, we have underwent exploratory laparotomy and blood clot was removed.
Correct. So I'm at exploratory laparotomy only. The hemodynamics was still quite compromised, correct? She was bleeding. She had a coagulopathy. She metabolically we had optimized to some extent. And at this stage, if anesthesiologist says this patient needs further optimization and she's kind of unfit for going for surgery. So how will you interact with the anesthesiologist?
Which control surgery can be done?
Again, please.
Damage control surgery can be done, sir. In
So anesthesiologist is kind of refusing at the beginning that this patient is very unfit and she may die on the table. And this obviously will be needed to be communicated because in such situation, the consent or informed consent is taken always together. Obstetrician, intensivist, and anesthesiologist. And if anesthesiologist initially differs on this and he or she doesn't want to take, then how will you convince anesthesiologist? Yeah, this is the damage control and life-saving surgery.
Sir, as it is a life-saving procedure, we have to take her on risk of death. We have to take her, sir. We have to explain them. We have to explain the attendants as it is life-saving procedure, and we have to explain the anesthesiologist also. We have taken
they were your friends, and I think you were able to convince them immediately. Any suggestions you would like to give them to, because you may not accompany patient in the operation theater. So any friendly suggestions would you like to give the colleagues from anesthesia?
As she is bleeding, we have to monitor her urine output. Her vitals have to be monitored every 5 minutes, and the blood quantification of blood loss also has to be monitored.
Limit the duration of surgery to less than 90 minutes.
Yeah. So all the management which was going to prevent hypothermia, to prevent any metabolic or hemodynamic derangement has to be continued as aggressively what was, or even more aggressively in the operation theater as well. And you would be available for the help in case they require to do. Okay. So exploratory laparotomy was done, as you said. Was it done?
Yes, sir. It is done, sir.
Okay,
Diagnostic laparoscopy with clot evacuation was done. With intra findings of 1 liter of collected blood and peritoneal lavage was done. And again, 2 PRVCs and 4 FFPs were given in the, and RDPs were given in the OT. And she was shifted to the ICU, sir.
So what was the, it was from the surgical site only, from the ward?
Yes, sir. It was from the surgical site.
Was it bleeding, but it was, or is just a collected blood?
It was collected blood only.
So there was no active bleeding going on.
Yes.
So that's what my initial question was. How did they come to conclusion that it is a surgical bleeding and not a coagulopathy bleeding? So do you think this operation was necessary or unnecessary?
Sir, 1 liter of collected blood.
That could be taken out from drain only. No? Clots will remain, of course. Clot can't come out of the drain because one big surgery decision for only taking out the clot can sometimes be risky. That's what I'm saying. They did a diagnostic laparoscopy first, correct?
Yes.
Or a laparotomy was done?
Laparoscopy, sir.
Laparoscopy was done. Okay, that's a better choice. Okay, further. So instead of exploratory laparotomy, they did a laparoscopy and then evacuated, correct?
Yes, sir.
Okay.
On
That
day
would be
4,
better because why I'm saying why it would be better to do laparoscopy than laparotomy.
sir, she is having coagulopathy. Diagnostic laparoscopy is a better choice than laparotomy, sir.
Okay. It will save time. It will because see incisions obviously will call again bleeding. She's in coagulopathy. So any further surgical intervention of laparotomy kind can prove a little more not disastrous, but obviously it can be deleterious. So I think laparoscopy, if they have done, that would be better choice. And just because if you see the active bleed, then obviously you may need laparotomy sometime. But here the operating area is actually, the raw area is very small, and unless there is some more injury before, but unlikely it was a regular obstetric hysterectomy done outside. So we don't know what exactly they must have done surgically, how much raw area, etc. So anything which is going to make a blood loss more a possibility, like laparotomy, obviously will be more deleterious, and that is the whole emphasis I'm trying to make. Next.
On day 4, patient hemodynamics got better and she was conscious and oriented. We have given a spontaneous breathing trial and was extubated to the face mask.
Dr. Prathiksha, whenever you do a case presentation, don't use subjective terms like better. Give the values. Nah?
Yes, sir.
Yeah. Okay.
Her coagulation profile and hemoglobin and platelets were also improved, and her ABG was also improved. Her hemoglobin on the day of extubation was 8.9, and platelet count of 55,000, and total WBC count of 9,1100, and ABG also got improved. So with lactates of 3, we have sent her to the out of wards.
Dr. Keerthi and Dr. Prathiksha, whenever you interpret ABG, you start from the top. First is tell the pH, whether it is acidosis, alkalosis, what is the primary disturbance, is the compensatory mechanism adequate. Proceed in a very, very systemic way, because this will be a separate station also. So ABG interpretation, you have to be very thorough and stepwise. If you misstep, you will miss findings also. Okay. So can you explain this ABG stepwise?
Sir, we have to first calculate the validity of ABG.
How do you do that?
H plus ions is equal to 24 into PCO2 by bicarb, sir. They will use the H plus ions and we should convert it to the pH, sir. Should see the pH if it is acidotic or alkalosis. So pH of 7.4. If it is less than
this ABG, you tell me the findings, the salient findings from this ABG.
Actually, pH is not visible. pH
7.53. 533.
7.33.
533. 533.
7.533. It is alkalotic side, sir. With PCO2 of 26, it indicates PCO2 is less and it indicates respiratory alkalosis. And PO2 of 166 with 5 liters of oxygen and bicarb of 22. So it is respiratory alkalosis, sir.
So did you extubate the patient now?
Yes, sir. She was extubated, sir, onto face mask.
So whenever you have a patient with obstetrics like PPH or eclampsia, what are the particular things you will keep in mind before extubation of such patient? Any obstetric patient, what are the issues before extubation you think about?
They decompensate very quickly. Their FRC will be very low.
They will decompensate on TPs if they have to decompensate. TPs is more difficult to breathe. Workout breathing is more than spontaneous breathing. What particular concern after extubation I'm telling?
Reintubation will be difficult.
Why?
Because of airway edema.
Yeah. So what do you do to check whether there is airway edema or not? In this particular patient, not all patients, in this particular, especially obstetric patients.
cuff leak test.
Yeah, cuff leak test should be done in a obstetric patient where the chances of airway edema are there. Okay, please proceed.
So this, so a few questions more. This was on 14, that means day 3rd or 4th. My first question is regarding if you did not have a CRRT machine, what would be done? When you started CRRT for this particular patient, decision was, what was the indication of CRRT here?
Sir, she is anuric and she had severe metabolic acidosis, sir, with the hemodynamic instability. So we have started her on CRRT, sir.
Yeah, so many hospitals may not have a CRRT machine. So what will be done in that situation?
We can go for slow low efficient dialysis also, sir. SLED can be done.
What is the difference between these two?
CRRT is a slow process of removal of solutes and fluids, sir. With we use VVHDF, venovenous hemodiafiltration we use, sir. In case of SLED, it is only dialysis only with the slow with the blood flow of 150 ml per minute, 200 ml per minute, sir. In case of SLED, whereas in CRRT it is 100 to 150 ml per minute.
So if available, obviously that will be preferred. Coming to the blood gas report on the electrolytes. Now, what do you signify by this 125.9 sodium, 2.28 potassium, and 2.8 in milligram percent that is given? So, and chloride is 96. How do you interpret this?
She is having hyponatremia and hypokalemia, sir.
Why this is so, and what will you do about all this?
Maybe dilutional.
Yes, we have transfused her with so many blood products. Dilutional hyponatremia might have occurred, sir. And
so this is on day 4 almost, because your dates are correct. Then did the blood gas analysis in between show similar picture, and were there corrections possible and done?
Chloride was higher in the first ABG. 115, if I remember it. Initially, it was hyperchloremic to start with. Hyperchloremic, sir. It was 113 or 115.
This is day 4, so I'm sure at least 3-4 must have been done in between. Assuming they have been correcting continuously. Now we can say what will be the plan for this now? How will you correct all this? Patient is stable, conscious, as you said, she's already extubated, but these problems are there. Will you like to correct or leave them alone?
We should tally with plasma values and laboratory values, sir. And then we should go for
if the laboratory values are same, what is shown here then?
Sir, we have to correct hypokalemia, sir.
What about hyponatremia?
Patient is
conscious and coherent. We can wait on hyponatremia.
Can wait, okay. Potassium?
Potassium we have to correct, sir.
How will you correct?
40 milliequivalents of potassium chloride in 40 ml of NS at rate of 10 ml per hour, sir. Not correcting more than 10 milliequivalents in for 24 hours. Through sir.
I'm talking about potassium.
With magnesium sulfate of 2 grams IV loading should also be given along with the potassium.
All patients.
No, I'm asking. Sorry. Yeah. I'm asking potassium dose.
What is the normal requirement of potassium?
We'll come to magnesium.
Yeah. Normal requirement of potassium per day is how much?
2 milligrams.
What? No, I didn't get it. What did you say?
Sir, 2 milligrams.
potassium requirements in milliequivalents in 24 hours is approximately in milliequivalents. How much it is? Okay, it can range from 80 to 160, almost 200, depends. So that is the yes question answer. But in this particular patient, now you want to correct it. It is much beyond that requirement, because daily requirement, so we have to give anyway. That must have been given in the ICU continuously if it was low. Now it is low. So what kind of replacement will you start with? How many milliequivalents per hour approximately? How is it available anyway? In your ICU, how is it available? Potassium?
Potassium chloride, sir. The solution it is available is potassium chloride, sir.
What is the content of that ampule?
Total 20 milliequivalents will be there in 10 ml of potassium chloride, sir.
Right. So how will you plan the infusion?
Sir, we usually start with 40 milliequivalents, and then we repeat the electrolytes and then see the electrolytes, and then we again give like that we'll give.
40 milliequivalents in how much time?
40
That's the crux of the
milliequivalents.
matter.
Sir,
In how much time do you give? Bolus?
Sir, no, sir. 40 milliequivalents diluted to 40 ml of NS with 1 ml equivalent to 1 milliequivalent, and at rate of 10 ml per hour, that is 10 milli.
Approximately 10 milliequivalent per hour. That should be better idea. Okay, fine. That's okay. Maximum you can give up to 20 milliequivalent per hour. Nothing more is advisable, because there will be. Why not give more than 20?
Electrolyte disturbances leading to cardiac arrhythmias.
Yeah, so there may be a cardiac affection directly if the higher rate more than 20 is given. So recommended is up to 20 millicurrent per hour. Dilutions as you can do, and you had said correctly, the content of the ampule is usually 20 millicurrents in the 10 ml. What about calcium?
So we are talking about central line. Remember, all the audience also. Dr. Bande is telling 20 milligram through a central line. So whenever you prescribe potassium, Dr. Keerthi, Dr. Prathiksha, tell how much, what dilution, and what route. You should be very, very clear, because we all have seen if potassium is not prescribed very seriously and diligently, accidents can happen. So prescribe it very, very clearly. Don't be vague. Yes. Next question is, sirs, calcium.
Next question is calcium, because I always even previously I told ki the triad is now expanded to diamond, that becomes quadrat, and hypocalcium is added in that, and it is equally important. And the value being so low, what are the problems with such low calcium in the body?
Leading to coagulopathy, sir, and impaired muscle contraction. Tetany can happen, and
the plateau phase of cardiac action potential will be prolonged.
So there are multiple sites where it will happen. So it is our duty to prevent any hypocalcemia, because which is quite eminent due to various reasons which we just now saw. Now, how will you like to correct it?
We correct it by giving calcium gluconate, sir. 10% calcium gluconate given over 15 to 20 minutes, sir. It can be given through central line or peripheral line. We can
You start with at least one ampule going off calcium gluconate or even chloride, and you know the differences between two. You previously said that it will take some time to correct, because we probably will have to repeatedly give these injections in due course, depending on what level you are reaching. But I think 3 or 4 ampules may be needed. In massive transfusion, that the usually dose required is quite high. So you go according to the estimations, or empirically also many people give in the beginning itself when you are giving other blood components. Often it is required like that. What about chlorides?
Chloride, sir. Okay, sir. Chloride level is okay, sir. It is 96 millimoles per liter.
What is your lab range?
Sir, 90 to 110, sir. 90 to 110.
Okay, 90 to 110. Fine.
Another thing is,
if IV fluids are to be given as a maintenance IV fluid, what is the output at this point of time? Was there output, or She was anuric or oliguric?
Sir, she is pouring up 50 ml per hour output is there, sir.
So output is normal. So not what maintenance IV fluids are planning for this patient?
Maintenance of 1
She's NBM,
ml.
correct? She's probably will be NBM still. She's undergone another laparoscopy. If she
Maintenance
has a
will
good output, then you will need a maintenance fluid, correct?
maintenance of 1 ml per kg body weight we should give, sir. To avoid dehydration,
What fluids you will take? Decide.
we will give balanced crystalloids or we can give RLs, sir.
Normal saline.
What is the content of sodium in RL? Or Keerthi, I don't know who's Keerthi and who's Prathiksha. She said normal saline. So is there any choice? Better normal saline as a better choice, or you go by balanced salt solution like ringer lactate? And what are the content of sodium contents of either these?
Sir, sodium content in NS is 154 millicalories, sir. And in RL it is around 130.
130.
Sir.
All right. So will you prefer sodium? Because sodium is low, will you prefer sodium chloride? And chloride also on the little lower side. So will you prefer normal saline or you will continue with ringer lactate?
We can give NS, sir.
All right. Yeah, fine. That all depends on how efficient is the kidney, because if kidneys are not excreting sodium adequately, you can decide whichever is. But then sodium chloride obviously will give better option in this situation where sodium is rather on the lower side. But you'll need a repeated monitoring of electrolytes at least 12 hourly, if not more frequent. Correct? So fluid you can decide, output, hemodynamics, and biochemical parameters all will decide your composition of IV fluids which are going on. What about other balanced salt solutions? Because there are other balanced salt solutions than ringer lactate available. If somebody says like plasma light and there are many other similar lights available, how do they differ from ringer lactate? Both are balanced salt solutions. Have you used plasma light or any similar fluid? Gabi light, and there are many available. Are you using those anywhere?
Yes, sir, we are using, sir.
Where, which cases are you using? Where will you use balanced crystalloid versus a normal crystalloid?
So I am asking them other balanced crystalloids, those which are not discussed so far, plasma light, Gabi light, and similar ones, serofundin. So these have some different compositions. So are you aware about that composition? And are they indicated in this scenario? Your junior comes and said, we have a better solution, why don't we give that? Then how will you answer the question?
You also use balanced crystalloid in the beginning. Why? Why are you using balanced crystalloid in all the patients or in this particular patient you use?
Sir, she is prone for more dyselectrolytemia. We should give balanced crystalloids.
So whenever the chances of hyperchloremic acidosis is high, or if hyperchloremic acidosis is already set in, then you should go for balanced crystalloid. So the major thing is either for prevention when you suspect that you have to use large amounts of crystalloids, or when already hyperchloremic acidosis is set in. One more point I wanted to raise here is whenever there is
sorry, no, I just wanted the answer. The other balanced salt solutions, how do
you are mute, sir. Mute ho gaya. Dr. Bande sir, you are mute.
Are you aware about other balanced salt solutions which are available?
Yes, sir.
So where have you used them anywhere?
Yes, sir, we have used plasma light.
Where have you used it? Plasma light. So how does it differ in a composition with the ringer lactate? Where have you used anyway? What was the indication when you used it?
Used in
Anyway,
acute,
you can revise.
used in acute pancreatitis, sir. Where fluid resuscitation is needed in large amounts, so we have used in acute pancreatitis.
We'll go for, we'll not get stuck on this. What I'm again requesting, you know the composition appropriately and the indications also appropriately. So we'll go ahead with this. Go further.
Another one point, whenever there is respiratory alkalosis, hypocalcemia will be precipitated. So always correct the alkalosis also. Do not leave alkalosis like that.
Yeah, why the patient is constantly alkalotic? I mean, respiratory alkalosis. Now this is on spontaneous breathing, correct? Even previously on controlled breathing also she was little on alkalotic, respiratory alkalotic side. Anyway, next.
Next, please.
Sir, her urine output improved to 80 ml per hour and hemodynamics are stable with BP of 120/80, pulse rate of 80 and respiratory rate of 18. With saturation of 98% on room air, and she was mobilized out of bed. We sent her out of ICU to the wards.
What was the situation about nutrition in these 4 days when she was with you people? How did you look after the nutrition part?
We have started her on a tropic feed, sir, with 20 ml per hour of 1 calories per ml of per ml. We have started her on tropic feeds, sir.
What?
Sir?
What have you started?
Tropic feeds, sir.
What is that?
Sir, to preserve the gut motility, as he is very hemodynamically unstable, to preserve the gut motility and prevent the bacterial translocation from the gut, we have started her on low amount of feeds that targeted the 20% of her daily caloric requirement. We have started her on 20 ml per hour of feed with powder feeds with calories of 1 kilocalories per 1 ml, sir.
Was there hypoglycemia at any point of time?
No, sir.
What I saw, you have inserted a nasopharyngeal, nasogastric tube or a orogastric tube?
Nasogastric tube.
Why nasogastric tube in such a patient who is already coagulopathic? Always long-term use, we should put orogastric tubes in the ICU. Now we are moved out of, especially patient is so coagulopathic, we should avoid nasal tubes. Okay, so always use orogastric tube. Next, please.
Was X-ray chest done any point of time?
Yes, sir. We have done just X-ray, sir. Daily we have done.
Was there any abnormality seen in the X-ray?
Abnormality was seen.
Nothing was normal. They were normal.
Yes, sir.
Okay, go ahead.
Okay. So
you can ask the question, Bande sir and Dr. Yash, related to obstetric emergencies. You can ask the questions, not a problem. They just presented the case, which was their live case, which are in the ICU 15 days before. Whatever the questions are there related to obstetric, you can ask it. No problem.
So Dr. Keerthi and Dr. Prathiksha, firstly, good case and nicely presented, but you should go very, very systematically. Do not use subjective headings, better, good. You have to always give numbers. Nah? If you give objective data, it will be good for the examiner and it reflects on how caring you are. And as Dr. Bande also pointed out, whatever relevant investigation you should always put, even if it is normal, you should put and give the lab data in a chart format or in a tabular format so that it has a good visibility. We'll start with the questions. What was the cause of bleeding in this patient finally? What was the and you have not written the final diagnosis. always give the after the case presentation, tell about the case. This is my final diagnosis, and explain about the diagnosis in 3-4 slides. So, what is your final diagnosis?
A 27-year-old female with G2P1L1 with PPH, sir, atonic PPH with severe postpartum hemorrhage with disseminated intravascular coagulation.
Why do you say DIC in this particular case?
Sir, she had oozing from all the ports and drain also. And she had intraperitoneal oozing also, sir, from blood vessels and with low fibrinogen and with the prolonged PTINR, we have suspected disseminated intravascular coagulation.
And how do you substantiate your diagnosis with clinical labs?
Sir, in DIC, there will be thrombocytopenia, elevated PTINR and D-dimer. And thrombocytopenia, sir, and with in peripheral smear there will be cystocytes, sir.
So this all will be there in coagulopathy of liver disease also, and there is a good overlap. So DIC is always a clinico-pathological diagnosis. Only lab parameters or only clinical picture will not diagnose. You can suspect, but you cannot diagnose. How will you further substantiate? In any massively bleeding patient, the lab data will be same, what we saw in this patient, whatever is the etiology. Final pathway becomes the same. So what are the scores you use for DIC? Do you use any score in your practice?
Yes, sir.
Tell me one you are familiar with.
International Society for Thrombosis and Hematosis.
What is that score?
IS score.
More than
25.
More than 5 is over DIC. Less than more than or equal is over DIC. Less than the parameters in that are D-dimer, platelet count, prothrombin type.
Yeah.
D-dimer, platelets.
What else?
Prothrombin time.
Platelet, FDP or D-dimer, whatever you have, PD, fibrinogen, these are the parameters. Okay, so if the score is say 2 and the patient is bleeding, will you leave it as it is or you will?
No, sir, we have to repeat the lab values.
Okay.
It can progress to frank DIC.
So DIC is a dynamic disease, we all know that. And the ISTH scoring also should be done dynamically. Any critically bleeding patient, high risk patient with severe infections, eclampsia, you should be doing this score whether patient is overtly bleeding or not. What is DIC? How do you define it? Simplistic definition of DIC.
It's an acquired syndrome characterized by intravascular coagulation with the loss of localization arising from different causes, either originating from the microvasculature leading to organ dysfunction.
So what is main thing in this definition is widespread deposition of fibrin, and there should be loss of localization, as you rightly said. Loss of localization is also there. So what are the major complications of DIC? Is bleeding common or coagulation common?
In acute cases, bleeding is more.
In acute cases, bleeding is not more common. No, still bleeding is not more common. Acute cases also coagulation, procoagulation or DVT complications like this are more common. Bande sir, kuch aap बीच में?
In case this third surgery or third procedure which was planned and had relatives refused this particular procedure, what would be the prognosis of this?
Sir, prognosis will be the same, sir. If she doesn't have any infection of hematoma that is collected in the abdomen.
So was the discussion there at that time in case relative, because to undergo third surgery, relatives always will have a reservation. We always take informed consent that patient may deteriorate perioperatively. And it's not uncommon that patients will resist the decision. We often try to convince, but there was a possibility that it may be a surgical bleeding also. We don't know, because there was reasonable collection by your ultrasound evaluation. Luckily, this patient did not have a surgical bleeding, because often they bleed from the vault and the raw area. A small arterial spurter, which is missed in the shock status, bleeds later. That can be a complication. So it's very difficult to decide, and the volume, which was much higher, probably was prompted them to take a decision of exploration. No, I mean the laparoscopy now in this case, and I think that was a good decision, though it turned out to be negative for surgical bleed or arterial spurter, or significant venous oozing which would need cauterization, etc. That was a good decision, and these decisions need to be taken faster and timely, because if you lose more time, then obviously the bleeding will continue, the coagulopathy and all biochemical derangements will continue. It's very important how we convince the patients in this situation what is appropriate and what can happen. So prognostication at this point becomes a major decision, and that has to be done by reasonably senior people. So what did they use in the anesthesia? What did the notes show? What anesthesia was given?
General anesthesia was given, sir.
What drug did they use?
They have induced her with fentanyl, sir, and with rapid sequence induction and intubation, they have proceeded with ropronium, sir.
Patient was already intubated, na? Well, she has gone from the ICU. Na?
Fentanyl, what else did they use? That's all.
Sir?
Fentanyl was the only anesthesia. They write the notes, isn't it?
Sir.
Yeah, you don't need much, because you cannot give any other. What are the other anesthetic drugs you are using in ICU? Are you using any anesthetic drugs in the ICU for sedation, analgesia?
It immediately used for intubation.
How did you manage analgesia in the ICU for this patient?
Sir, fentanyl. We have given her fentanyl.
Commonly fentanyl. Okay. You have propofol also used for any such patient?
Patient is hemodynamically unstable.
So you will not use propofol. Okay. Yes, Yash?
Yeah, what all monitoring did you did for this patient while she was in your ICU? First day or second day?
Sir?
What all monitoring?
Sir, ECG.
Yes.
ECG,
Blood pressure.
invasive arterial line, invasive bit-to-bit monitoring of BP, sir, and temperature monitoring, ETCO2, and urine output, and
SpO2, obviously. So ETCO2 you are using for all the ventilated patients?
sir, very sick, for very sick cases.
No. ETCO2 you should be using for all the ventilated patients, for all the airway procedures, and for all the ventilated patients as a dictum. Okay. So going back to our case, okay, tell me the complete diagnosis. Still you have not completed the diagnosis. You have missed on one thing. AKI also was there, which reversed. So always your diagnosis should be very, very complete, and it should be reflecting. And suppose this patient was still bleeding when they did the laparoscopy. What was the option there?
We can go for uterine artery embolization.
Have you seen a patient going uterine artery embolization? For a patient who's obstetric bleeding, it is very, very difficult and time consuming at times, but it is before hysterectomy most of the time. Okay. And what are the other causes of DIC which you have seen in your practice for last, say, 1 year?
So, yes, I will just interrupt here because
Yes,
it is
sir.
a relevant.
Yeah.
When I asked her if the patient had refused the surgery, so that is one option if to see by having radiological evaluation or imaging done by dye injection to find out if there is a bleeding from anywhere. So if that is so, then embolization can still help if there is a bleeding from vault or raw areas. And if surgery is deferred by a risk and prognostic on those grounds, then this is less invasive. Though it will be needs a tertiary care center. I'm sure you all have that. So that intervention radiology can help in this situation in case surgery is to be avoided, and there is a strong possibility of some surgical bleeding. So that was one point which I forgot that time to mention.
So any major, like sir pointed out, any major gynecological postpartum bleed or even GI bleeds also, where your medical management is failing, with the surgical consult, always ask for intervention radiology opinion also, because it will come handy. It could be a risk reduction strategy to control the bleeding as well. Yeah, reasons for DIC which you have seen in your practice in last 1 year.
Sepsis, sir. We have
Yes.
seen 4 cases of sepsis.
Yeah.
And trauma.
Yes.
And major surgeries.
With what major surgeries?
For malignancy, we have done
Solid tumors or hematological malignancies, and transfusion reactions. Do you get snake bite?
Yes.
So snake bite, have you seen a DIC picture anytime?
Yes.
No. And heat stroke is another cause which you should be familiar with.
One question: what is the role of tranexamic acid in the whole scenario? Was it used any point of time?
Yes, sir. Day 1 we have used tranexamic acid.
How much? What in what dose?
1 gram IV over 10 minutes.
Only once, or it was required later on? What is the mechanism of action? How does it help?
It binds, it blocks the lysine residues on plasminogen, inhibiting the conversion, inhibiting the action of plasmin. It's an antifibrinolytic.
At what stage the fibrinolysis occur in the coagulation cascade?
Common purpose.
Sorry,
Common purpose. The last test.
So WHO guidelines do mention this to be given as 1 dose, and if required,
within 3 hours.
if required. So if the hysterectomy was not done outside, what are the other measures to control if the uterus was in situ and patient was still bleeding? What other measures are undertaken?
For refractory PPH, sustained
intrauterine balloon tamponade with intrauterine balloon tamponade can be done, sir. And bimanual massage of
bimanual
fundal massage of uterus can be done.
Bimanual is different, fundal is different. See, fundal is from fundus. Bimanual is one hand above the abdomen, one into the vagina and to the uterus.
Also, aortic compression also.
Before that, before aortic compression?
The first line of management is uterotonics, tranexamic acid, resuscitation with the IV fluid, and as early as possible, we have to use blood products. Refractory PPH, we have to do either radiological procedures, uterine artery embolization or Ribova.
No, see, step by step. We have done fundal pressure, bimanual compression. What after that?
Vacuum. We can use vacuum suctions.
In intrauterine packing can be.
Yes, and after intrauterine packing, lynching suture. Do you remember?
Yes, sir. Uterine compression.
Uterine what are the complications of uterine compression with these sutures? It can necrose, infection can happen, and then you have to obviously initiate antibiotics in such patients at least.
What is the policy, antibiotic policy perioperatively?
There is no fixed consensus regarding antibiotic policies, sir. Some people prefer one dose of antibiotic.
No, in this scenario, as per your hospital policy, patient was operated outside twice. What antibiotics were given, or were they given at all?
Yes, sir. We have given her BLBL, sir. We
and
started her on Pepperazone, sir. Vectum.
See, do not give BLI when INR is already deranged. It will further increase the INR. So never give. This is one contraindication to BLI, if at all. Yeah, do not give BLI when the INR is already deranged and patient is bleeding. You have to stop BLI in such patients. See, Dr. Bande's question is very clear. See, what type of surgery? Is it clean surgery or what surgery will you consider it?
This is contempt.
Now, I think after 2 surgeries outside, so we have to give antibiotics. So the question is, as a generalization, whether we will give antibiotic or not, if at all, what is your hospital policy? And as Dr. Bande pointed out, any critically ill post-operative patient, you have to take a very detailed anesthetist and OT history also. Do not just take a handover with no idea. Always take full information. At times, surgeon will try to hide something. At times, anesthetist may try to hide something, or they will miss telling you. So always take a very detailed handover for a critically ill post-operative patient. Very important. And whenever a patient comes after a major surgery, repeat your blood gas, repeat the vitals, the temperature. Okay. Sir, anything else? Yeah.
aerobic
There were
is
some. There are few questions in the
Chat box.
in the chat box. So just looking at that. Can cryoprecipitate be given in massive ongoing bleeding as part of massive transfusion protocol, even if fibrinogen level is unknown? I think you have to correlate with the bleeding, and till then you can wait, because fibrinogen, if is not known, we assume it to be low in this scenario. If clinical bleeding is going on, I think it will be wiser to give components in a combination, which was already mentioned. CRRT temperature adjustment, I think that all is done. Have we done FDP in this? Have we done means given? I believe
FDP fibrinogen test maybe, sir. They're talking about fibrinogen degradation product levels.
Yeah, it
Nowadays,
doesn't make
I
much
think
sense, because so it doesn't make much sense. They will be anyway there. Even of the previous surgery, they will be there. So if no dialysis machine present in the casualty, how to proceed? I mean, nobody is going to do dialysis in casualty. Patient, how to proceed is to bring the patient to ICU and then decide whether she needs dialysis in the ICU. No need to do dialysis in the emergency itself. Hypotensive resuscitation for 45 minutes. I don't think hypotensive resuscitation in this case has a particular role, because hypotensive resuscitation is done usually when the patient is being transferred from outside, that to patients of trauma, where possibility of increase in blood pressure causes dislodgement of blood clot and bleeding will worsen. That is the usual intention of hypotensive resuscitation. In this case, we have definite targets. We did not go into details of those targets, because we have hemodynamic and metabolic targets to be achieved when patient is with us, and we have reasonably precise parameter monitoring and assessment with us. Potassium requirement 1 to 2 milliequivalent per kg. If it is mentioned, then is the answer to Dr. Yash's question, which will not be correct, because as I said, requirement is from 80 to 160 to almost 200 milliequivalent per day. So per kg, it will go to almost 2 to 3 milliequivalent per kg at least, if not 1. How to correct hypokalemia? Exact values to know how much to infuse. And Dr. Prathiksha clearly told that 10 milliequivalent per is a good rate to start with. We do have almost 6 hourly assessment of potassium, continuously being done till the time we are happy with the potassium level. And infusion can be increased if required to maximum 20 milliequivalent per hour. And I think we discussed that. Ringer lact at 131 and normal at 154 was answered correctly by somebody. That composition has been described by somebody correctly. Okay, then did this patient receive LASIK during ARA because before CRRT? We need not ask because there was, I think, quite early decision of CRRT, which was absolutely perfect because this patient, and I think that is very, very important. And the way patient improved metabolically and even hemodynamically, CRRT decision taken early was a very wise decision because there can be always delay in that decision because of the cost involved is also more, and sometimes there can be inter-consultant difference on that issue. How to correct hyperchloremic acidosis with normal KFT and oliguric case. Now, hyperchloremic acidosis, obviously you restrict the chloride intake, which will be in terms of sodium chloride, which is not to be given. You can replace it by balanced salt solutions. And if normal KFT, you don't have to worry because KFT may worsen in due course. And in oliguria, if there, obviously we have to try a diuretic. In case diuretic doesn't help, then obviously we'll have to go for some kind of renal replacement therapy. Intrauterine balloon tamponade in PPH, it still has a role, and I think we spoke about it. Are there any transfusion targets below which we have to give FFP, cryo, and platelets in patient with DIC if there is no bleeding? Now, it's as West continuously said, DIC and this coagulopathy, they are a dynamic process. At one time, you may find bleeding there, and next 1 hour, you might find collection in the abdomen. So it's very, very difficult to assess to assess and manage and monitor also this kind of coagulopathy where you have to suspect continuously that there is going to be a bleeding because we can never be appropriate and adequate in replenishing the components which are lost in a massive bleed. So I think it's a dynamic process irrespective of dilution of DIC, dilutional coagulopathy or hypocalcemia and hypothermia contributing to coagulopathy. We have to have continuous monitoring of coagulation parameters, hemodynamics, and prevent all these metabolic and temperature, etc., which will have a direct relevance to the coagulopathy. Role of tranexamic acid, I think we discussed about it. How to insert invasive line in coagulopathy case and difficult cannulation. I think people have now ultrasound guidance with us, and somebody expert or some senior has to take a call for this. And if you want to be precise enough, I think a bigger artery can be chosen rather than radial, where it may be more constricted than femoral, which will be little larger. And ultrasound control obviously helps. But at any cost, this is very essential and has to be done unless patient is really going to improve rapidly, which was not the case in this case, as well as it is not the case in most of the patients. So I think arterial management of blood pressure is very, very important. That is the whole list. What is RDP was answered. How to know if ABG is valid? I think they started telling, and I don't know whether this question was answered. How to know the ABG is valid? Prathiksha, are you still around?
Yes, sir.
Yeah. So how do you know if the ABG is valid? We actually bypass this question, but you can answer.
There is a formula, sir. H plus is equal to PCO2 by bicarbonate into 24. We have to correlate the pH with the H plus ions, or we can minus 80 minus the last 2 digits, and if the two values are equal, then ABG is valid.
So there are 1 or 2 ways doing it, and we always, in case you suspect, what may be the reasons why ABG can become invalid?
Calibration is
over heparinization, sometimes dilution, all these can make it invalid. And in that case, you have to repeat the sample, nothing more in that. So can 10% dextrose be given? Yes, I think I asked that. Calcium gluconate has 4.6 milliequivalent and chloride has higher quantity. That was answered there. Okay. So the question, no more questions in the, is there anything in the chat?
Yeah.
No, nothing.
One valid question, sir. When to start DVT prophylaxis? Any critically ill patient in your ICU, you should have to think about DVT prophylaxis. Low molecular weight heparin is generally used, but patient actively bleeding, you have to only use the mechanical compression device. Do not use in an actively bleeding patient. If you are not giving DVT prophylaxis, your note should write the reason why you are not giving the low molecular weight heparin prophylaxis. High risk patient combine mechanical and drug LMWH both. That's it, sir.
So luckily, this particular patient I think they manage it very well because CRRT was started right early, which helped in metabolic as well as the hemodynamic and temperature, etc. In all ways. These patients, why I asked about X-ray, because initially the transfusions and infusion are going rather unmonitored, and very high chance that these patients may land up in pulmonary edema. It often used to happen, I remember. And that is because overzealous transfusions and infusions going without real monitoring. Now we have a lot of monitoring. Now my question to Prathiksha and Keerthi is, what is the role of ultrasound and echo in having better precision in hemodynamics? Because we to keep on giving large volumes in this. So how do you manage this hemodynamics in your ICU? Ways are obviously CVP monitoring, ultrasound. Are you using ultrasound for or IVC distensibility and collapsibility, etc.?
Yes, sir.
For precise fluid management.
IVC distensibility index less than 20%, we can give fluids. Then we can also evaluate the cardiac function. Before giving fluids, we should know whether the cardiac status is good. Also, we have been transfusing a lot of blood products. We have to see whether there is a B profile lung ultrasound or pleural effusions. So that is.
I think that's a summary of what we is doing. I mean, there are so many listeners still around, and it's very important that we use these extra recent advances in ultrasound for IVC evaluation as well as echo and of course the lung assessment, because we can definitely prevent pulmonary edema. Because once pulmonary edema occurs, definitely ventilation goes further by 24 to 48 hours minimal. And if the renal insufficiency is there, it can further be prolonged before we undertake any kind of renal replacement therapy. So these are advances and which should be now commonly used in most of the hemodynamically unstable patients or shock of any variety, and we can diagnose it more precisely, and of course have a therapeutic better options and precision in all kinds of shock, not only hemorrhagic shock.
Bande sir, just addition. I hope the massive transfusion protocol has been discussed. Sir.
Not particularly, we did not label, because all the parameters or what are the components of massive transfusion were discussed rather separately. So this patient initially only started having, and they described
so
it.
We will take some questions on that, sir, if possible. Prathiksha and Keerthi, what is the massive transfusion protocol, and does this patient fits into massive transfusion protocol?
Yes, sir. Anticipated or actual PRBC, 4 units of PRBC transfusion with hemodynamic instability plus or minus ongoing bleed, we have to initiate a massive transfusion protocol. There are 4 rounds in our hospital. Round is PRBC, platelet FFP 666 plus a cryo rate of 10. So second round is also same. Third round, we give 1 gram tranexamic acid over 10 minutes. Fourth round, 666 without cryo.
No, I'm asking about when you call them massive transfusion.
What is the trigger?
Replacement of more than replacement of 1 whole blood volume in 24 hours or more.
That is one definition, but you will not wait for 24 hours. Your patient has no time. Your patient has not even given few hours.
If patient is requiring more than 4 PRBCs in 1 hour, then we should offer
50% blood volume in 3 hours.
So there are 3-4 time-bound definition in 24 hours, in 1 hour, in 3 hours. So these are the patients where you will trigger. Sir Bande sir and Javeri sir, I have been to this I've been a part of the same case when I was in the same unit during my rounds, and we had a long discussions in many of these obstetric critical care forums where this case was also put across and discussed. And nowadays, like a code blue, like a stroke code, like this, there is a PPH code.
Yeah.
So a patients where there are prophylactic PPH code which is ready and geared up, and there are also PPH codes which happens unexpectedly, unanticipatedly. And this PPH code starts from the OT. There will be a runner boy with some samples already ready with him, and the blood bank has been alerted with a particular blood products as we are talking about. And this PPH code team has shown to be effective and helpful in many situations, because some of these patients with a very bad placenta previa in a different positionings, which will not go into details, the obstetrician do anticipate sometimes, and sometimes it happens like this case where it is not anticipated. So we are talking about PPH code, which actually saves life, like code blue, like Met teams. We all know that PPH has been one of the most common cause of obstetric deaths across the countries like which are resource limited settings like India or Southeast Asian countries. And they were talking about PPH code team in the centers where there is a good amount of facilities available has shown to be improving this death, which is something was a part of my learning during those work interactions with them. And what are the complications you expect in these patients? You keep on going transfusing these patients. I think altogether there were around 40-50 units blood products packets has been transfused. So one is trigger. Once you transfuse, what are the anticipated complications in them?
Just one brief comment before the answer. So there is a provision of code crimson, especially if trauma is there. Code crimson is any major life-threatening bleed. So you can probably club everything.
Club
any
everything.
major
Okay.
trauma.
In major polytraumas
Yeah.
also they trigger a massive transfusion protocol. So all these will come under that same
code crimson.
Okay.
Yeah.
Makes sense. Makes sense. Sir, anything from your side, Bande sir? ऐसे कुछ
No,
attempts?
we in our hospital we have there is no PPH code as such instituted so far, but we have a polytrauma code just like code stroke and others. So maybe this can be extended. That's a good
Extended,
idea.
exactly.
Not,
And they say that the PPH deaths are extremely high compared to any obstetrics deaths in any setups. So,
obviously. So in all the major hospitals, we have various codes. Polytrauma code can be extended to these
yes,
obstetric
exactly.
bleeding as well. So we don't have to have another code team for that, but it will be approximately same. And our polytrauma code has surgeon, radiologist, intensivist, and anesthesiologist all included in the team with additional nursing support.
Any combination of products you want to give whenever you anticipate a massive transfusion protocol?
Transfusion related acute lung injury. Transfusion.
No, I'm asking what will be, okay, we'll come to that. What will be the components when you wanted a massive transfusion protocol to be followed? What will be the ratio of the products, or you will give a packed cells only?
1:1:1, sir.
Is there any recent evidences varying with this? And do we have evidence in PPH or in some other areas?
Prompt and proper trial is there. In proper trial, 1:1:1 versus 1:1:2 did not show any mortality benefit at 24 hours or 30 days. However, it decreased the mortality by exsanguination in 24 hours.
Can you explain it again? Two, what is 2? 1:1:2, 1:1:1?
PRBC is to FFP is to platelets.
So what is 2? See, 1:1:1 is 1 packed cell is to 1 packed 1 FFP is to 1 RDP. We are not talking about SDP in that they are emergency situation. But when we say 2:1:1, 2 packed cells is to 1 RDP is to 1 FFPs, and there they actually didn't find any mortality benefit in later arms, but this, yes, as you said, exsanguination related deaths. were different. And but is this in obstetrics care? No, it is in a trauma backdrop that study. So right now, even major trauma guidelines still follow 1:1:1 whenever we come across this transfusion related protocol. But I think this can be extrapolated. Suppose you have a compromised state, you don't have a FFPs, you don't have a RDPs adequately in your unit at that point of time, it got exhausted. You still can consider 2:1:1 because those are equally even effective in those situations. Maybe one component of that was not addressed, but it still can work. So we have now evidences in favor of that also.
Even
is there any comment on that, sir?
Yeah, even in this case, if you see the lab parameter chart which was shown, the coagulation almost got corrected. Almost I'm saying because patient still had a clinical bleeding, but the hemoglobin was very low still, 3.6 or something. So what you were saying correct, because coagulation may get corrected and patient will still remain anemic with the formula 1:1:1. 1:1:1 formula came from the Iraq war times when Americans actually that time somebody did the study rather than giving a random, because whole blood was also available to them that time, but they compared and they found 1:1:1 probably was better way or precise way, and from that it has been followed. But it needs a very continuous and dynamic monitoring of the coagulopathy and cell parameters as well, because we often may be under correcting, especially the RBC part, and which happened in this case. So any formula which can be taken as a guideline, but I think we need a continuous monitoring of the parameters, and that will be at the discretion of intensivist in the ICU, depending on each case on its own merit.
And now, as we are using TAG or ROTEM for all critical beats, so we are wiser with that data, and we are avoiding unnecessary that product usage.
I think TEG or ROTEM can guide you in supplementing this, whether you can titrate with 1:1:1 or you need any more fibrinogen or more platelets, or you don't need both of them. Any fibrinogen targets, Prathiksha and Keerthi?
Sir, in this particular case, fibrinogen should be maintained more than 300, sir.
So 200.
So no, so they are not, they are disagreeing with each other's opinion with 200, 300. And what is the general fibrinogen target in a non-obstetrics patient? Whenever you are dealing with the DIC?
It is 200 in normal patients, sir. It is 300 in obstetric patient.
So generally we considered 100 and above of fibrinogen target in a non-obstetric patient, but in obstetric patient there were different guidelines. Starting from 270 onwards, there were some updates which are talking about 200 or more than that. Sir, any light on this, the fibrinogen targets in a active PPH patients? Bande sir and
yeah, no, I don't think you said it correctly, because 300 or 270 will obviously be a good answer to be followed. And as I said, we need repeated monitoring. And if you want only kind of go only on the fibrinogen as a parameter, which may not be always correct idea, but it has to be a comprehensive approach to the whole coagulopathy. But the target of fibrinogen to be achieved by giving cryoprecipitate, I think around 300 is a fine for correction.
So, sir, as you pointed out, sir, TEG and ROTEM may not be available in many centers. Let us be more honest. I think majority of the centers may not have in-house. So maybe the other indirect way is active bleeding and fibrinogen targets. So the other question is, both Prathiksha and Keerthi, you have 60, your target is 300. So you have around 240 or 220 to correct in these patients. So how many FFPs will be required to correct them? That's where the the cryos comes into play, where you give a boluses of cryo to counterbalance. Otherwise, you will end up in leading around maybe 4 liters or 3 liters of extra volume to them. Any comments on that, sir, where the cryos has been recommended? Yes.
I'd like to comment on the previous question also. See, if fibrinogen level is less than 100 with DIC, then we have to always replace it. Less than 100 for actively bleeding patient.
Actively bleeding non-obstetric patient.
Non-obstetric patient. Otherwise, 150 to 200 is the general acceptable thing. Or patient going for surgery with a bleeding patient going for surgery, non-obstetric.
Coming to this other question, sir, we were talking about the replacements with FFPs will require a lot of volume. So that volume will be a big challenge. So we try to give a cryo to cut down the volume and in a concentrated way. So that's where we try to consider around 10 to 20. I still remember in this case, we pushed around 20 cryos standing there. The hemostasis achieved after we reaching that a number around 200 or 250 fibrinogen. Till that time, she was just the whole showcase of all those dressings were very evident with the drain tubing, and the bag is fully filling in many of the situations. And the last probably question or addition from my side is, what are the anticipations? We have done all this very great that with maintaining the hemostasis, we could actually bring back the bleeding problems. But what are the other problems we create when you transfuse 40 to 60? I believe this patient altogether received around 60 units of products or more than that. So what happens? What will be the other problems in that?
Transfusion related acute lung
So what
injury.
are they?
It is a non-cardiogenic pulmonary edema associated with hypoxia, sir. It can be either early or delayed, early within 6 hours or delayed within 72 hours transfusion.
Anything else? Only that?
Mechanism is
No,
I'm asking other complications.
transfusion associated circulatory overload, or
Okay.
if
How do you differentiate between both of them?
one is cardiogenic, one is non-cardiogenic. So one is because of volume overload, and the other one is due to
How do you treat the TACO and how do you treat the trial?
supportive management for both, along with diuresis for TACO.
And for trial?
Trolley oxygen supplementation.
Supportive care. Will you have any evidences in favor of or against any other drugs which have been used and tried or tried? Okay, direct question. Role of steroids in trial. So no clear evidence in favor of or surviving. Other than TACO trial, what are the other complications with transfusion related massive transfusion?
When we give large volume stored blood, each unit will have 3 grams of citrate, which will cause hypocalcemia.
So what will you do? How you will replace hypocalcemia, treat hypocalcemia in them? Do you replace them? You will watch for some toxicity. What will you do?
We will, if there are symptoms, we will
replace. You have to replace with the calcium gluconate or calcium chloride, sir.
When you will replace with all patients, or
sir,
you will keep on watching for the symptoms and also maybe ECG changes, or when you are actually replacing it very rapidly and you don't have any way to monitor them and regulate them, then some of the institution may consider replacing them. What are the other complications of massive transfusion? Sir was talking about hypothermia. So with these all products, when you're giving in such a rapid way, these all measures may not act. So you will land up in hypothermia. Dilution coagulopathy, if suppose you're giving 1:1, that may get at the end, you may also land up in a lot of volume logging. So third spacing, volume logging and all.
And risk of multi-organ dysfunction will be increased whenever you give multiple transfusions. Risk of ARDS is also high whenever you give. Apart from TRALI, ARDS can also happen. So always ventilate this patient as per ARDS net. Hyperkalemia is again not uncommon in such a massive transfusion. Always look for hyperkalemia and treat it accordingly. And risk of infections, if there are more blood products, there is immune dysfunction, risk of secondary infections is also increased. And there are various other complications which should be listed for many more. Transfusion related AKI is also not rare if such a large amount of blood products are used.
This case also had some LFT dearrangements. So any lights, Bande sir, uske upar LFT, if you see the enzymes were little higher.
Yeah, it was already written in the chart as a conclusion of ischemic hepatitis, and I agree with that because with shock status, this is usually the finding, and
Yeah.
initially you may find in thousands. With improvement, I think of the shock, the things get better, and I think only the next day they were half of the levels. So that is one good explanation for that. And if there is bilirubin rise, often isolated can be seen if there is no hepatitis, only because of hemolytic transfusions, because of hemolysis is there in some transfusion units. So bilirubin levels may go isolatedly high because of that hemolysis. So these are seen, but I think we all know this, and then subsequent evaluation probably it's evident with that these are not something else but usual complications.
I think what we have not tried to go into details is the management of the problem initially, the PPH. So that anyway is a part of obstetricians where you will have a supporting role, but pushing them for the source control and making them a part of the team, that will also, because so many times there will be a game saying you stabilize the patient, will take, the patient is too unstable to go. And we say he will only get stabilized when you actually take the hemostasis onto count. So that which is first will be a discussion. So it has to be a teamwork. Both teams should be put together and should push with all the blood products. And I think nowadays we are also seeing a lot of help from an interventional radiologist. Any comments on that, sir? IR comes a rescue in many situations.
Venkat, both these issues we tackled in a subtle manner, because when I talked about informed consent, obstetrician obviously will be in the picture, and the decision about intervention has to be a team decision, and including the patient as a fourth component, because that's where the more resistance counts for any such life-threatening or life-saving surgery, so it is called. And the interventional, we did talk, if the uterus was in situ, that is one option if available in the hospitals where intervention is efficiently done, because as Yash said, it is time consuming and the decision may not be very prompt. An intervention versus obstetric surgical approach, there can be some disputes at the beginning, and patients will not have much choice in this. It is totally a team approach of all 3-4 of us to decide which will be best for this particular patient. And often surgical probably will be best in most of the situations, given at this point the expertise and the availability of radiology, interventional radiology. So that all has to be kept in mind, and each case obviously will need its own decision on the merit.
So whenever we are going for hysterectomy or embolization, we have to keep in mind that the patient has finished her family. If not, so decision can be. But again, the life change takes over the decision about hysterectomy or ligation. In the intervention arm, they either do proximal artery ligation, uterine, or anterior branch of uterine leg, depending on their angiography. Another thing which we missed was this: there is a balloon also which is available, especially in centers with high obstetric load, Bakri balloon. They inflate the balloon and it causes tamponade. Not commonly being used. I haven't seen it being used, but it is available.
Yes, I think it's available, and it is damage control phenomenon.
Yeah.
Bakri balloon.
Bakri balloon, yeah.
So yes, was the role of PCC. Word about PCC.
See, depends on your tag finding again. But if you are FFP in cryo, you are in a very big center, your blood bank is efficient, but not all blood banks are this fast and efficient. If it is not available cryo, then you should go for PCC.
I think FFPs, PCC will have only the 4 factors which are available with that, and expensive. It's extremely expensive. 40,000 for 5,000 units. You may land up in needing around 20,000 for 2 lakhs, 3 lakhs rupees. That's a big challenge.
But at times there is nothing which is available. Blood products after a certain time they finish out. But again, it is a compassionate use only. Ideally, we should be going as per the protocol.
Okay, over to you, Madhu.
Thank you, Dr. Yash and Bande sir, for extensive discussion of the cases. Almost we were running for more than 2 hours. and we had attendee about more than 190 people who are attended live already on the Facebook. And I think it is quite famous by seeing the examiners, Dr. Bande sir, and yes, a lot of people joined from India and outside India also. And subsequently, after recording, I think more of hundreds and thousands of people will be watching about all the things. Thank you, Dr. Keerthi and Dr. Prathiksha, for presenting a nice case, and I got a good discussion.
So generally, what happens over a time, sir, in a live sessions will be a couple of hundreds, but over a day or two, we see around few thousands who reach this, because we both make this available in Facebook and YouTube. And I put my gratitude and my heartfelt thanks to both of you, Dr. Yash Javeri sir and Dr. Bande sir, you being available and sharing your wisdom and knowledge, and making both the students and all the group aware of all these possible questions and answers. We thank both of you from my bottom of hearts. Thank you.
Yeah,
Thank you.
thanks for the opportunity, Venkat.
Thank you. Pleasure is ours. Thank you, Dr. Madhusudan. Thank you, Dr. Venkat. And well done, Dr. Keerthi and Dr. Prathiksha. Thank you.
Thank you, sir.
Have a good day.
We'll close for today. Thanks a lot. Thank you.
Okay, thanks.